Уважаемые коллеги, я надеюсь,
So, dear colleagues, I hope that those who are being late will join us later on, but we do not have enough time in order for our guests to be able to make the complete presentation. I think we'd better start now. And what we are going to do, first we have the presentations, and then our doctors from Austria and Germany will make the presentation first, and then we will speak about how Hospital 52 works. So I would like to announce that what we will have here. When we were speaking about a nephrology session, and of course we could have chosen lots of topics about nephrology, but one of the most important topics is the provision of medical care to patients using hemodialysis. And fortunately, by giving life to patients, by starting a replacement kidney therapy, we do not do everything as it should be done. And the patient can die because of complications. And the situation itself, it may seem strange. This situation has an important economic impact. When we are treating the patients for a long time, he stays in the hospital or undergoing massive AB therapy. I don't think this is the good thing for the patient. That would be the right thing to provide for prevention of infectious complications, which can develop at long-term hemodialysis. Let us think that was the announcement of the purpose of our section. So I think in the end you will have questions. I really hope you will, and we will try to address all of them at our meeting. And the first presentation will be done by me. So the next one. In the first slide, you see that at present in Moscow, we have over 50% of patients on long-term hemodialysis, and we try to develop peritoneal dialysis, as she is quite small. And as for kidney transplantation, which provides for the best quality of life for the patients, is developing now in Moscow, but the program hemodialysis as the only method of therapy which doesn't have contraindications, practically all of the patients which need hemodialysis, they get it. So you should not be confused by such small letters on this chart, but this is the data from the report of the Commission of the Healthcare Ministry for 2019. And Moscow is #1 in terms of the number of patients on replacement kidney therapy, and also for the number of patients on program long-term hemodialysis. Moscow is one of the leaders. And the same is true about patients on peritoneal dialysis and patients after kidney transplantation. And what is important here, provision of care to patients in intensive care units. Every year we gradually increase the number of patients that needed replacement kidney therapy with acute kidney damage. And these patients who are the patients which may need dialysis, chronic dialysis, and we are interested in those patients actually in terms of how to provide care to them. Looking at different years, the number of patients on program hemodialysis is constantly growing, but this is the trend which is not as big as peritoneal dialysis. Only last year the number grew quite considerably, and we could have had more patients because our transplantologists take patients more eagerly from peritoneal dialysis for kidney transplantation. And as you see, in the last year, there was a considerable growth in the number of patients after successful kidney transplantation. What I would like to tell you about, and there is a constantly growing number of patients on long-term hemodialysis. This is the price of patient treatment on hemodialysis, and this cost has different elements. And hemodialysis patient, this is the most expensive patient that we have. And this cost includes not only the cost of the procedure itself, not only the drugs, medical treatment, and transportation as well, which is costly, and high share of hospital stay. If we are talking about transportation, we are successfully addressing that issue. You all know that. You know that in Moscow, we work on optimizing transportation of patients. Every year we open new dialysis centers, and we decrease the length of the route to deliver patients to the sessions of hemodialysis. Before this work was started, patients would be brought 40 kilometers to the center of dialysis. Over this period of time, we decreased this distance by 4,000 kilometers per day. With the help of opening new dialysis centers, and this work will continue, and the trend of the dialysis service in Moscow is to make as much centers as we can. We are opening new dialysis centers, small ones with a slow capacity in different regions of Moscow. In 2013, we were talking about covering in districts. Now we are talking about covering sub-districts. Look at these numbers. In 2019, there were 219 cases of hospitalization with signs of catheter-associated infection. And what is concerning us the long hospital stay of these patients. And the treatment is usually very expensive. And though the share of such patients compared to other diseases is not that high, but it's quite considerable share. And this is the goal of today's discussion and exchange of opinions. And I try to voice what we would like to see in the future when we will have solved all of the dialysis problems, when every patient has hemodialysis provided from those who need it. But we need to address several issues. We need to start this therapy on time, and then we need to provide regular and necessary diagnostics for patients before hospital to decrease urgent hospitalizations. And of course, we need to decrease the share and rate of complications. And what depends from you and us, we need to decrease the number of hospitalizations which can be prevented. And I am finishing my presentation by saying that when we finish our session, if you have questions, I'll be happy to answer them together with our honorable doctors. The professors whom you see on the stage are Dr. Klaus Gerdes from Germany and Dr. Gürkan Söngilge from Austria, and they are dealing with prevention of catheter-associated infections, prevention of such infections. And I'm happy to give floor to Professor Klaus Gerdes for his presentation.
Thank you for the introduction here. Can I have please the first slide? So this is the Russian version, and can I have the English version also, please? Is this on the here? Okay, this is the English version you see. I thought it's up there. Thank you very much. So what I want to talk about you over the lecture about is catheter lock solution. So what is a catheter lock solution? Normally, if you have a catheter, you fill in a special solution to have patency of the system and to avoid infection. So there are different methods to do this. Normally, in former times, you use heparin. Heparin is not an antimicrobial, but heparin is an anticoagulant. So the flow, maybe with heparin, is quite well, but there is no protection of the system with antimicrobial lock. So lock solution is in the catheter when it is not in use. If you use the catheter, you pull out the lock solution, discard it, and you begin, after flushing with saline, with hemodialysis. I focus only on hemodialysis now. So the prevention of catheter-related bloodstream infection, I call it CRBSI instead of CA, associated bloodstream infection in central lines. There are some new results, and I want to show these results here. So the requirements for lock solutions, or call it modern lock solutions. So there is the antimicrobial effectiveness. That's an important point, as you heard before. Then it's the maintenance of patency of the access. That means a good flow. This is necessary for the patient, for the doctors, and especially for the nurses, because the nurses want to have a good flow. And then a safe application. So even in the case of incorrect use, this means if you over-instill the lock solution into the catheter, there should be no harm for the patient. So what we do is, with the lock solution, we want to have a prophylaxis, better than cure. That means avoid from the first insertion of the catheter that the catheter will be infected inside. And you have to avoid that there will be biofilm inside the catheter. So we focus here on hemodialysis, but there are also other applications of a lock solution, especially in parenteral nutrition patient. On the right-hand side, you see the port system for parenteral nutrition. On the left hand, you see typical catheter for hemodialysis. So the application for drugs in oncology with Portacat, Broviet, or Hickman lines, we do not address here, only hemodialysis. So there may be some different pathways of infections. First is a contaminated catheter hub. This means that you can get endogenous skin flora inside the system. And then the other harm can be the contaminated infusate. Both contaminated catheter hub and contaminated infusate is rare because you have to work carefully so you can avoid this. Inside the system, there can be transportation of microbes via the blood, and these microbes can sit down inside the surface of the system. Some microbes, like Staph epidermidis, they like to sit down on surfaces, and then they build the biofilm. If you want to avoid this, you have to do a prophylaxis, and you start with an antimicrobial lock from the beginning. Then the risk factors. How are the risk factors divided between different points here? So the risk factor is a previous catheter infection. If you have a catheter infection and you salvage the catheter with antibiotics, the risk for the next infection is relatively high. You cannot eradicate the old biofilm inside the system. So the next risk is 30 to 60% higher than the first risk. Then a typical diabetic patient. Then the implantation site. Femoral is worst. Best is, or the same is, subclavian jugularis is the same. Then long-term catheters. So catheters more than 90 days are a higher risk for infection because the formation of biofilm is inside the system. And the increasing age of the patient. If, citation here by Cano, if you use strict aseptic manipulations and if you use an antimicrobial lock, the infection is as low as 0.5 infections per 1,000 catheter days. This was a study with 2,230 patients. So the number here, 0.5, is extremely low and nearly perfect. 0 is not to achieve, but 0.5 is perfect if you use all the hygienic standard and antimicrobial lock solutions. So first, what is normal is a good hygienic standard. That means hand hygiene, skin disinfection, and disinfection of the exit site. So you have the normal situation you use for the exit site, chlorhexidine or other antimicrobial, to avoid that microbes go via the exit site into the patient. And then you have the typical, historically interesting, non-antimicrobial lock solution like heparin 100 up to 5,000. So heparin 100 was usually used as a lock and flush solution. So you lock the catheter with the heparin, and then before hemodialysis, you flush it into the system. You can do this because the concentration is very low. This can not be done with a 5,000 high concentration heparin. So you have to aspirate the heparin. So with the lock in flush solution, there's a high risk because if there's a development of a microbe inside the system, you flush the microbe into the patient. So this have to be avoided. And then the well-known saline, also called lock and flush. So you lock with saline with antimicrobial effect, and you flush the saline into the patient before starting with hemodialysis. Okay, how can you prevent catheter infections if you use antimicrobial locks? There are different ones in the literature you found now, until 2020. They are the so-called antibiotic locks called AL. This is gentamicin as a citrate. The citrate is the anticoagulant to get a better flow. Then you can use vancomycin, daptomycin, EDTA with minocycline or without minocycline. All are not approved and so-called off-label. So there is no antibiotic lock solution approved worldwide. Non-antibiotic lock solution. Now it's getting very interesting. You have the high concentrated citrate, 64%. This is approved. I show you some slides about that. Effectiveness is relatively unclear. Then you have a 30%. Effectiveness, not so good, relatively unclear. Then you have ethanol, 70%. For oncology patient and parenteral nutrition patient, very good, excellent. 70%, it's not approved. And the 70% is relative high concentrated ethanol. lower concentrations are not active. Ethanol 30% and citrate 4% approved. Studies are rare. Then taurolidine citrate. That taurolidine is an antimicrobial in combination with 4% citrate called Taurolog HEP 100 in combination. Then Taurolog HEP 500 and urokinase, and the American product, only in the moment not approved, is Nutrilene. Not approved means in US, in Europe it is approved. Okay, we start a little bit historic, because it's quite interesting what started in 2007, the history. Here, so you see some studies here. A gentamicin study, citrate in combination, double-blind randomized, infection rate. On the right-hand side, you find the comparator arm. It's heparin 5000 and the infection rate per 1,000 patient days. So you find the double-blind study here, 4.2, relatively high infection, 0.1 with gentamicin. Typically with gentamicin, extreme low infection rate, but the risk of resistancy problems with the microbes. P is the significancy, highly significant. Then cefalozin, heparin, gentamicin, the combination, double-blind, nearly the same effect. In the one arm, 0.4, in the comparator arm, 3.1. Trisodium citrate, 1.1, 4.1, not bad. Gentamicin heparin without the citrate, nearly the same with this combination of citrate. Cefotaxime heparin, double-blind randomized, also a reduction, but not so good, 1.56. Taurolidine citrate, open-labeled randomized, 2.1 in the heparin arm, relatively low, and 0 in the infection rate in the experimental arm. So this is the literature, the relatively old literature, and now we go step by step through the log solutions. So requirements, we go to the antimicrobial effectiveness and the prevention of the infection here. In the end, the installation procedure. So we start with some log solution recommended in various guidelines. So there's a German dialysis standard here, and ERP-BP and the Katoki guidelines and so on. And you find that they suggest highly concentrated citrate, 30%, 46% in taurolidine citrate. Those solutions can be used as a log solution, an antimicrobial log solution, and in general now, antimicrobial logs are suggested. Also in the position statement of the European Renal Best Practice, the preventive use of antimicrobials is advocated to reduce the CRBSI. The problem with the National Kidney Foundation, gentamicin citrate and taurolidine solution is used as interdialytic antimicrobial logs. They are effective, but be careful with antibiotics like gentamicin. They can affect the problems with the resistancy in the microbes, especially as a log solution because the concentration is relatively low. Okay, we start with the sodium citrate-based logs. There's a 4%, there's a 30, and there's a 46. Now I show you some original publications, sodium citrate 4%, and I marked here the bacteremia in red. There's in the left, you see the heparin, and you see in the right the citrate arm, the experimental arm. Number of infections per 1,000 catheter days. Heparin arm, 24, means 0.7, and 35 means 0.94. Significancy, 0.36, no significancy. So you see there is no reduction of the infection rate with the 4%. This is understandable because 4% citrate is not an antimicrobial. Then 4% citrate versus heparin. reduction of thrombosis studies. It's quite interesting. You see the catheter dysfunction, same. The catheter-associated bacteremia, CAB, 6 in the heparin arm, 5 in the citrate arm, not significant. So you see in both studies, you see that there is no reduction of infection rate and the thrombosis rate is nearly the same. Now a bigger study in France. Hemodialysis catheter in critical ill patients, multicenter, randomized. Number of patients, 396. It's very, very high number of patients here. In the citrate arm, 199, heparin arm, 197. So I marked some outcomes here. Interesting, thrombosis of the first tunneled hemodialysis catheter, 9 in the citrate, 3 in the heparin, not significant. Incidence rate per 1,000, 6, 1.8. Local first catheter reductive infections, 7, 8, not significant. As you see in this big study in Dijon, in the Bourgogne, in 2019, there is no reduction of infection rate and the thrombolysis is the same. Now we change to the interesting one, the 30%. So there was a study here by Maristela Bölke in Brazil, in Sao Paulo, 2017. Comparative effectiveness in comparison to heparin, lock solution, randomized controlled trial called Citrim trial. So in the heparin group, you have a total of catheter days, 7,000 nearly. Bacteremia total, 3.4. This is normal. Catheter dysfunction, 9.4. Now we change to the interesting point, now the citrate group. 6,000 patients, total catheter days, 6,000. Bacteremia total 5.2. It's higher. It's higher than the heparin arm. This is amazing. Then catheter dysfunction, 11.4. It's higher than the dysfunction in the heparin. So in both criteria, the bacteremia rate is higher and the catheter dysfunction is higher. So the CRBS-free survival in the citrate group was significantly shorter than this in the heparin group. So this is, in the first moment, this is astonishing. I'll show you later why. Now let's look at the 46%. It should be, the higher the concentration, the better the reduction of the infection rate. Okay, look at this here. This is by Albert Power in England, American Journal of Kidney Disease, 2009. Catheter-related bacteremia in the citrate arm, 0.7. Extremely low, but in comparison, 0.7 in the heparin arm. That's the same. So also extremely low infection rates. Then, but more interesting is the use of urokinase locks to open the catheter for a good flow. You have citrate, 8, and heparin, 4.3. So you have a highly significant more use of urokinase in the citrate arm. Despite the citrate is called an antithrombotic agent, anticoagulant. This is amazing. And the 12-hour urokinase infusion is also higher in the citrate arm than the heparin arm. You can find also this high concentrated citrate, sodium citrate, in catheters in critical ill adults, randomized trial in France. You see the microbiology here. The microbiology in the control group and the sodium citrate group is nearly the same. So there seems to be no reduction of infection rate in the high concentrated citrate arm. Okay, let's look at the taurolidine Tauroloc catheter lock solution. We have the Tauroloc HEP 500, we have the 100 and the 25,000. We only discuss here the Tauroloc HEP 500 and the Tauroloc U because this is for hemodialysis patients here. So we have this 500 with a concentration of taurolidine 1.35 in both solutions, also 4% citrate, and heparin in one arm and the urokinase 5000 international units per ml in the other arm. Let's have a look at the antimicrobial effect of this tauroline citrate. The taurolidine is the antimicrobial. Look at the Taurolog, the heparin, and the Taurolog Hep 500 on one side. So you see killing rates here. These are typical bactericidal killing rates for antimicrobial compounds here. So in the Taurolog left-hand side and the Taurolog on the right-hand side with the combination of heparin, the killing rates are the same. So after 2 hours, you are nearly zero. That means in this case, detection limit of colony-forming units. You see the logarithmic scale of colony-forming units versus time in hours. Look at the heparin. After some time, after 4 hours, you have a development of microbes in heparin. This is quite rational because heparin is a sugar derivative, it's an oligosaccharide, and microbes like the sugar of the heparin, the sugar configuration of the heparin. So we have a broad antimicrobial effect against more than 500 germs. This is also published here in 2000. Especially vancomycin-resistant enterococci and Pseudomonas aeruginosa and Candida albicans. They are the worst case here. Also the resistant methicillin Staph aureus here. So look at these studies here, the comparison of tauroline citrate Taurolog versus heparin. There are different studies here. Please omit the oncology and the parenteral nutrition and the ICU because it's not so interesting for you. Only the dialysis, the first chapter here. So there is Allen, Betius, Taylor, Solomon, Murray. So the studies are US, Netherlands, United Kingdom. And the year, starting from 2003 to 2014. Infection rate per 1,000. In red is the tauroline citrate. In black is the heparin. So you see typically 0.5 versus 5.6, 0, 0.6, 1.3, 0.7, and heparin higher, between 5.6 and 1.7. 1.7 for heparin is excellent. Normally in Europe you find 5, 3 per 1,000 catheter days. This is all hemodialysis here. Now let's have a look closer. The United Kingdom study here. This is a tauroline citrate heparin study here in hemodialysis patient. 12,000 patients in the Taurolog Hep arm and 6,400 catheter days, sorry, in the heparin group. You see the bacteremias total, all bacteremias, 3.25, and in the experimental arm, 1.3 significance. Gram negative, 1.24, gram positive, 2. Staph aureus, 1.4. And the reduction here, all bacteremias total, 1.33, and all other ones, 0.4, 0.9, 0.5. And there is no difference in blood flow, means thrombolytic therapy and catheter patency here. The same with a study in Spain here. Comparison Taurolog Hep 500 to heparin, 1.08, extremely low, but we can go to 0.04 with the Taurolog Hep. And interesting here, the so-called positive side effect is the inflammatory profile is reduced. So we have a significant reduction of CRP and interleukin-6 levels in the Taurolog Hep 500 period. England, nearly the same. Hemodialysis days, 72,000. In the Taurolog Hep group, 63,000. I show you this because the days are so high. And the BSI, you have 115 and 43 in the Taurolog Hep group. So the infection with Staph aureus is 36 in the heparin group, and infection of coagulase negative staph 79, 1.6 is per 1,000 catheter days. And in the Taurolog Hep group, 0.7. This is a significance of 0.04. So now we start the most interesting part. This is a combination of the Taurolog-HEP and Taurolog-HEP 500 and the urokinase. So what we did is a study, 2 days, 2 dialysis per week. We took Taurolog-HEP 500 and over the weekend the Taurolog urokinase. So this was done in Hamdi Hospital here in Hamad Hospital in Doha. So we have the Taurolog-HEP 500 group with 93 patients, CRBSI low, because we have an antimicrobial low, 4. Rate per 1,000, 0.3. Not surprising, but the most surprising is now, if you use the 2+1 protocol over the weekend, the urokinase, in addition with the antimicrobial lock, you go down to 0.08. And the number of RTPAUs, 2.1, and the number of RTPAUs in heparin, 4.3 per 1,000 catheter days. So you have an enormous reduction of the infection rate if you use urokinase additionally, and you save money by the reduction of the RTPAUs. So I come to this later because Professor Sengelke will lecture about this special catheter lock here. This is the locking protocol in Vienna. Dr. Sengelke will talk about this here. So what we can do is we can also avoid the biofilm inside the system here. So if you look in the system of a catheter on the surface, you have a biofilm if you use heparin, typically on the left-hand side. In the middle is the heparin lock. We start with the left-hand side after some days, 24 hours after implantation and the heparin, and 7 months implanted, and you see if you use heparin, you have a covered surface of biofilm. This is a typical microbial biofilm. Not to please, don't mix it up with the fibrinous sheet inside the system. It's different. If you use from the beginning, prophylactically use an antimicrobial lock, you can see this after 5 months, there is no microbial biofilm on the surface in the system of the catheter here. Now, patency of the access. You see, if you use 46% citrate, as I talked before, you have a higher consumption of urokinase and a higher consumption of infusions of urokinase. This is a big question mark, what is going on with the high concentrated citrate. So this is a quite interesting experiment done by Professor Schilcher in Austria. He used blood and mixes with high concentrated citrate solution. And you see that after some time there's a precipitation of albumin. See it on the bottom of the flasks here. And it starts with more than 10% citrate. So you have a precipitation of albumin protein inside the catheter if you use a high concentration of citrate. And this blocks the catheter, and this means that you have the higher consumption of urokinase. This is the reason why. This is a catheter. If you use a catheter like this with a high concentrated 46% lock solution, the density of the lock solution is extremely high. So if you fill the catheter completely with this lock solution, the lock solution drops out on the right-hand side in the tip section. You see the red color of the tip section. There, the concentration of the lock solution is a minimum. Therefore, there is no prohibition of infection. If this drops out, this solution here, or they mix it with blood, this gives the precipitation of the protein inside the system here. The only left-hand side of the connector side, the orange colored, has the high concentration of the 46%, not in the right-hand side, because you have a lock spillage to the high density of the catheter lock solution. Okay, how do we instillate locks? It's quite easy. You flush, after hemodialysis, you flush the system with saline, a minimum of 10 ml or 20 ml. Then you instill the correct volume of a lock solution, whatever this is. Instill the correct volume. You have to know the filling volume of the system. And then you instill the lock solution. Then you close the catheter and the lock solution stays inside. Before the next hemodialysis, you aspirate the lock. You always should aspirate the lock, whatever lock solution you use. Then you aspirate the lock, you flush the system with 10 ml or 20 ml of saline, and you start hemodialysis. Just to remember you, there are some new publications concerning this handling. The use of so-called push pause or pulsatile flushing means that you push the saline solution for the catheter, to rinse the catheter, not in a laminar flow, but with pressure. So you use different pressure. This is called the pulsatile or push-pull-pause flushing. So there's a better cleaning of the system if you use, instead of normal flushing, laminar flushing in the system. Okay, thank you very much. If there are some questions, I think we should discuss after your lecture. That would be fine. Then you may start this with your lecture here. Okay, thank you very much.
Спасибо большое.
Thank you very much. Я встану.
Sit and talk. So if you don't mind, I'm gonna be standing. And we can start with the presentations. I'm from Vienna, from the University Hospital in Vienna. And the University Hospital, there is also the General Hospital. So it has both functions. It's the studying and also the treating patients. It's the same hospital. I think it's a similar system here, as I heard. Can we start the presentation? Yes. So, you know the title of my talk, and this hospital, that's the hospital I work in. That's the General Hospital in Vienna. And Vienna is really a beautiful city and has the ugliest hospital in the world, I think. This is, I don't know who permitted to be built, this hospital. And in this hospital, we have a unit. It's called acute dialysis, where we do our own interventions, our own catheters. We do about 900 central lines a year. So we are very involved in the implantation techniques, but also the maintenance. And so I'm going to talk about our toluidine-based lock. We serve the whole city, not only our hospital. So we serve about 1,000 dialysis patients, and we have about 80 PD patients, but actually primarily we have hemodialysis. So the background was actually perfect because Professor Herdais talked about it. This is I'm showing you the literature as well. It's all based on literature. And we have a major problem with dysfunctions and infections. So they go all hand in hand. The infection is an acute problem, but if the catheter doesn't work well, and if the dialysis quality goes down, that's as bad as the infection on chronic terms. So we need to stop both problems. And as you know, the second leading cause of death in dialysis patients, hemodialysis patients, is the infection. And the infection rate is between 0.2 and 6.5 cases per 1,000 catheter days in the literature. It changes from center to center. I don't know how the numbers are in Moscow, but for example, in Germany or Austria, and Austria is a very tiny little country, it's 8 million, the whole country, but there's a big difference between East and West. So we have higher rates of infection and higher rates of catheter in the East part of, for example, in Vienna, and on the western part, everything is lower. In Vienna, we have about 30% catheter in dialysis patients, which is very high. And as well, in the western part, for example, it goes down to 10–15%. And in Germany, there are centers or cities where one center has 30 and another one has 10. So it always changes, of course, about patient population of that hospital and how people are actually, or how the surgery is, fistula surgery, etc. They're all big factors. So the choice of an adequate lock solution is an important step in maintenance of these catheters. And I think we do not pay much attention to that. They have to have anti-infective and anti-thrombotic features, those lock solutions. And there's no clear recommendation regarding catheter lock solutions because there's no consensus in guidelines. Professor Herdaj showed you, and I'm just going to remind you, at the time of our study, for example, we had these the most recent, and you see how recent they are. They're all old, actually, and there's no overlap almost. Some say don't use the antimicrobial antibiotics, and others say it is recommended. So there's no real consensus. But you see that, you know, there's urokinase, alteplase, citrate, heparin. It's all over the place. Everything's there. So, and I want to make a point about why infection is really important, not only about sepsis, not about the chronic, but as you can tell, one of the risk factors for catheter-related central venous occlusions is the infection. Because the infection doesn't only make an endothelial damage, but it also is pro-thrombotic. So we are actually injuring the endothelium and having as an infection as a pro-thrombotic factor. So that's why there's a lot of thrombosis, stenosis, and occlusion based on the catheters. And I'm going to show you just, for example, this is a patient of ours. This is a lady who has huge collaterals, not only on her chest, but also on her abdomen. So all her body is full with these collaterals because all her central veins are occluded. And we have another, this is also a lady, younger patient. You see that the right subclavian vein is occluded. The contrast medium doesn't go further. This was actually only after one catheter, which was infected, and because of that thrombosis, her right subclavia was occluded. So we need to pay attention to infection, not only because of the septic problems, but also because of the central veins. So our hypothesis was that with a catheter lock regimen consisting of taurolidine, citrate, heparin, urokinase, we could reduce dysfunction rates as well as the infection rates in our hemodialysis patients if we compared to the 4% citrate, which was the standard, or was the standard in our, actually all over Austria. So why did we have that hypothesis? What was the rationale behind it? Because first of all, at that time, there was no comparative data. Secondly, taurolidine is a really nice substance because it is a broad spectrum anti-microbial, non-toxic agent. It reduces biofilm, no resistance, and no adverse effects, even if it goes into the circulation. And there are data which show that if you add citrate to taurolidine, then you reduce the CRI, catheter-related infection rates. And if you add heparin on top as a third agent, you have the better patency. And urokinase, there are also data showing if you use it regularly, especially in the pediatric, actually, the data are coming from pediatric patients. If you use it regularly, you have less thrombotic problems. Then you don't have to handle at the catheter. There's not much handling. And the less handling you have, the less infections you're going to get. and standard citrate 4%. So we said, okay, let's go and make a comparison. We designed a randomized controlled trial comparing these two regimens in Vienna, but in different dialysis centers, in 106 hemodialysis patients with newly inserted tunneled catheters. And I want to make a point of that because many studies, they compare the log solutions in prevalent catheters, or they don't make a difference between already existing catheters or new catheters, or the type of catheters. So in our design, what we tried to do was to have the highest level of standardization in both groups. So for example, we used not only new catheters, but we used only one type of catheter in all. So it was a silicone catheter, tunneled from the same company, all the same, no side holes, which is, I'm gonna show you another slide about that. And two physicians, two nephrologists implanted all the catheters based on the same bundle care. So the maintenance protocol was all the same for all patients in both groups. And what were these? And these are only couple. So wherever possible, we used the right jugular, all ultrasound guided placement. Patients were covered from top to bottom, and each patient had a nasal swab, and they got a mupirocin nasal ointment twice a day until we knew that they were negative, or until they became negative in Staph aureus cultures. Because we know that there is a lot of auto-infection from the nasal Staph aureus. So I want to show you, this is why we should never use side hole catheters, because side hole catheters first are good in flow, but afterwards they become worse and worse, and what they do is they have 10 times more thrombotic complications than the catheters without side holes. Because the log solutions, doesn't matter which log solution, it diffuses out, there's a vacuum, and blood gets sucked into the tip of the catheter, and then you have the thrombotic lesion there, which gets infected and which is also causing the dysfunction. So you've seen that catheter log solutions. These are the ones Professor Hardas showed you, the taurolidine citrate and heparin, and taurolidine citrate and urokinase instead of the heparin. And citrate was the citraflow. And that was our 2-to-1 protocol. What do we mean by 2-to-1 protocol? So the Taurolog group had, after the first 2 dialyses in the week, Taurolog citrate heparin, and after the 3rd dialysis of the week, before the long dialysis-free interval, it was taurolidine urokinase, and the control group or the comparative group was citrate every time. And the methods, in the outcomes, we defined the catheter-related infection was the primary outcome. And what do you think? Just think for yourselves, how many different definitions are there for catheter-related infections? What do you think? So at the time, when we did the literature search, we found 92 different definitions for catheter-related infections. So if some of them, for example, if you have a catheter and a fever, they define it as catheter-related infection, which is not necessarily true. So we have this definition which was published and which is practical. Positive bacterial blood culture drawn from the dialysis catheter in a symptomatic patient with fever or chills during dialysis with no apparent other source of infection. So if they're not anuric, we did a urine test, we did a chest x-ray, etc. And the secondary outcomes, the catheter dysfunction was the most important one. Also here the definition, what is a catheter dysfunction? We said if the blood flow goes below 200, or if the blood flow goes at least 30% below the average from the last 10 sessions, or need for catheter rescue with alteplase, which causes a lot of costs as well. Alteplase is the most expensive. And need for reversal of catheter lines. The other secondary outcomes were exit site infection, tunnel infection, episodes of antibiotic therapy, etc. So I'll show you details afterwards. So 150 patients we screened, 106 we enrolled, 52 randomized to Taurolog, and 54 to citrate group. I'm going to show you now the complete, but the flow diagram, which please don't try to read. I'm going to show you the results. I wanted to show you that was the complete flow diagram with the patients. So key demographics, age, gender, ethnicity, diabetes, C-reactive protein, etc. They were all comparable in both groups, no differences. And when you look at the primary endpoint, the catheter-related infection, Kaplan-Meier curve, it was a significant change in both groups. The taurolidine 2-to-1 protocol was much better than the citrate. And in numbers, it was like this. So 8,900 catheter days in Taurolog group and 6,700 in citrate. And catheter-related infection per 1,000 was 0.7 in the taurolidine or Taurolog group, and 2.7 was in the citrate group. And these are the secondary endpoints. Please just look at those which I marked. Catheter dysfunction is significantly lower in the Taurolog group. Need for reversal of catheter lines or alteplase rescue, and also catheter removal rate in Taurolog group much less than in citrate group. And not surprisingly, for example, we didn't have a difference between exit site or tunnel infections. And this is, if you look at the forest plot, you see favors Taurolog on the left, favors citrate. Everywhere where there was a difference between the two groups, the Taurolog group was better than the citrate group. And there was no difference, but there was no group where citrate was better. I'll show you just because it's interesting. We did also the analysis of the microbial spectrum, and as you can tell, the gram-negative infections were much less in Taurolog group than in citrate group. So, and we looked at the costs, because that's, of course, was interesting for the physicians, but especially for the management. So the Taurolog group cost per patient per year $1,485, and the citrate group only $187. But there was only the cost of the lock. If you looked at the whole picture, so if you included the hospitalization rates, if you included the antibiotics, the catheter removal, new catheter implantation, etc., all together, the costs reversed, and the Taurolog group became 43% less expensive than the citrate group, because all the complications were much higher in the Taurolog group. So the study conclusion, I showed you the protocol. The conclusion was it improved the catheter-related bacteremia rates, it improved catheter patency and cost effectiveness, and it did not make any change in exit site infections, tunnel infections, or cardiovascular events. So the practical consequence of our work was we had, in Vienna, we have the university clinic, and then there are city hospitals which are run by the city of Vienna. And they looked at the data. There were 2 conferences in nephrology units, and they decided to adapt this for all Vienna hospitals based on the cost issue, because if we calculate for 300 dialysis patients, in 30% of 1,000 patients, so 300 patients on dialysis catheters, the cost save was about $580,000 a year. And that was in the end the reason why City of Vienna adopted that protocol. So my take-home messages would be that in many patients and situations, we still need the catheters. We can't do without. We need to increase our fistula rates, but without catheters, there is no possibility. We need a bundle care. Each center needs its own bundle care. How you do the disinfection, the skin disinfection, what kind of catheters you use. And lock regimen is only one part of that bundle care, but it matters. We showed it and others showed it as well. And if you have an adequate lock regimen, that's going to give you better patency and low rates of catheter infections. That's also going to cause you less central venous occlusions and long-term less problems and better patient outcomes. And in our hands in that study, we show that the 2-to-1 torlock regimen had better outcomes and also less costs. So that was not our main issue as doctors when we did the study, but after the calculations, actually, we were surprised that sometimes the better solution doesn't have to be the more expensive one. So with these, I want to leave you, and if you have any questions, of course, we're going to discuss, and thank you very much for your attention.
Thank you very much, Professor Sengelge and Professor Grace. Пожалуйста.
Please, if anybody has questions, we have some spare time. Sergey Sergeyevich is going to introduce his report later, and I would like to hear your questions, if any, because it's a very rare, unique opportunity for us to ask our international colleagues. I believe that it's a very important issue to all of us, so dear colleagues, feel free to ask. Because Angela, do you have a question? Well, I was a bit puzzled by protocol 2-to-1 where there was use of heparin, and I do understand you used it once per week, and you used surokinase. I am not sure how precise was the study. It was expected that with such a scheme of introduction, 2.1 compared to citrate is going to show lower results. I don't offer anything, but I think it was quite obvious that protocol was not very objective. I love TowerLock, and I have a very big experience of using it, and I use it in this scheme 2-to-1, but I think regarding the trial, regarding the study, I had a few questions regarding the design. I think it would be more honest to use urokinase. And can we add urokinase to citrate? Can we add urokinase to citrate? Is it what you wanted to ask? What was? Can we use citrate? Can we use urokinase to citrate? No. I was talking about the protocol, the design of the study. I'm not sure that the design was correct for 100%. That's what I wanted to say. But I have no comments regarding the results of the study.
The question was, what will be the outcome if you use 2 times 4% citrate and over the long shift, over the weekend, urokinase? Okay? So the interesting point is, first, do we have a reduction of infection rates with 4% citrate? No. So, next question is, do we have a reduction using 2 times citrate and 1 time urokinase? That means if we would have a reduction, urokinase would be antimicrobial. This is not the case. But why can we see a reduction of catheter-related infections if we use urokinase over the weekend? There is more reduction. There is more. So the answer is, if you avoid clotting inside the system, you avoid infection. Because the microbe cannot sit on the thrombus. So if you avoid thrombus with alteplase or urokinase, you have a reduction of the infection. It's moderate, very moderate, but it is. If you use it in combination with an antimicrobial, it's highly effective. So there is a spiral. The spiral means if you use an infection, if you have an infection inside the catheter, you have more thrombosis. If you have thrombosis inside the system, you have more infection. So it's a spiraling down. If you want to break this, you have to use a fibrinolytic like alteplase or urokinase and an antimicrobial. That's a trick. That's the outcome. So if you look into the literature, you can find 2 publications by a lady from Canada, Hemmelgaard. Yeah? Hemmelgaard, yeah. In the first paper in the New England Journal of Medicine, I think, she published this urokinase or alteplase. The alteplase trial. In this trial, it is shown that once a week, alteplase can reduce the infection rate. This was like a revolution. But this can be that this revolution was initiated by the break of the thrombus. If you avoid the thrombus, then you get the infection rate down. In the second paper now, she published a year ago, there is no evidence for that. So I don't know what is going on. So there are 2 publications, one with a reduction, and 1 publication, the last one, no reduction. So there seems to be no evidence for that, but I cannot comment more. I only know in our case we have a reduction. Now, to your question, I suggest you do a clinical trial and look at these parameters. Use 2 times citrate and 1 time urokinase, and you will know. I cannot say positive or negative. I don't know. I don't know. You have to try. Never before, never had done this before.
First, I didn't have the translation, that's why I couldn't understand, but now I understood your question. It's a good question, and I'll tell you the reason why we did that. So, we were also criticized by some colleagues. They said, well, you are comparing the Rolls-Royce with a little Volkswagen. And I said, yes, you're right. But we were actually being told all the time, hey, Rolls-Royce and Volkswagen, they both drive. Why do you need a Rolls-Royce? And we didn't have the data. We were actually, we were not discussing about log solutions because everybody actually agrees we need log solutions. But in the conferences, because there are no data, people would say, it doesn't matter whether I use saline, flush, and log. We don't have any problems with that in our center, and we don't need anything. We don't need heparin, we don't need citrate. And we couldn't answer that question because we didn't have the data. And we designed this, and we show, and now actually 2 papers showed it. And now, in next step, you're very right, we could do another study. We shouldn't stop with this, and we shouldn't say, okay, this is the only thing which is working well. And we can study that protocol which you're suggesting. I think the main thing is we need to get more data out, because you've seen all the guidelines are based on very few data, and the more data we have, the more answers we're going to get.
Спасибо. Очень интересное предложение. Я думаю, что он...
Thank you very much. It's a very interesting suggestion. It's quite easy to do it because not each sentence in Russia used our log, but I would like to see more activity from your side, dear audience, because you will never get another chance to ask our distinguished international colleagues. If you keep silent, it means that you quite agree with everything you have heard, and conclusions are done by our Austrian colleagues. Evgeny Viktorovich, do you have a question? Because in fact, what we are talking about now, we are saying that we all have to work according to one standard, how to treat patients with program hemodialysis that due to certain reasons need catheters for central venous catheter. If we work according to one standard, means we will work as one team. If we all believe that here I'm going to work this way and I will use another standard in another place, it means, of course, experiments and tests are nice, but if you want to conduct a study, feel free to do it. You can do it, but please don't do it in my clinic. I'm joking, of course. I mean, please follow the standard. This is the most important thing. If there are no questions, please give floor to Sergei Sergeyevich, and then we will continue our discussion.
Can I just a comment? I had a discussion 1 hour before the lecture here with the doctor here in the room, and he said to me, what about this gentamicin? We are using gentamicin as a luxurious, it's fantastic. And I say, sure, it's fantastic. You see the numbers here, it's 0.3 in the trial. I showed you this. And I said to him, and you don't care about resistancy problems? Oh, no, it's no problem with the resistancy because gentamicin, it's no problem. So there are different publications now, especially from US, with a lot of patients with gentamicin. There, over the long term, 1 year, you can see the development of resistancy problems. The problem is not the gentamicin, the problem is the low concentration of the gentamicin in the blood. Because if you instill 1.2 ml of gentamicin, citrate or whatever, gentamicin, you have a spill out of the log solution over the time into the blood in extremely low concentration. That's a problem. Gentamicin is perfect, but as a log, it's not perfect. So there is a Brazilian publication from last year, Sao Paulo, Daniela Ponce. She did following. She mixed gentamicin with cefazolin against Tarolocap 500. And the outcome is no difference. I can say, fantastic, no difference. We are not better, but we are good like gentamicin, and we are not an antibiotic. We have no problem with resistance. That's the point, the important point. Antibiotics in the right concentration, massive, systemic, is perfect in special cases, but not in low concentration over a long period.
Спасибо.
Thank you, doctor. Thank you, professor. So you are reading my mind. This is exactly what I wanted to say for the discussion, but you addressed that issue yourself. Sergei, you have the floor. Good evening, dear colleagues. I wanted to start by saying that technological card of medical service on replacement kidney therapy log is included, but despite that, we from time to time get such medical documents which recommends a heparin log use for the central venous catheter, and they suggest the use of locks with urokinase, but why should we consider that? Taural lock is included into the list. In order to improve the quality of medical services to nephrological patients in 2019 in Hospital 52, we created Moscow Scientific and Practical City Center of Nephrology. And the algorithm was designed for dialysis accesses. If we see a patient which needs urgent replacement kidney therapy, meaning dialysis, and he has infectious complication, this person is hospitalized to ICU. We install temporary catheter, and after treatment of uremia and infectious complications, the patient is installed with tunneled catheter. After that, we can do the arteriovenous fistula or install catheter for peritoneal dialysis. After that, the patient can go for outpatient management of dialysis. If we see a patient which requires urgent dialysis but doesn't have infectious complications, such patient, we also install tunneled catheter, central catheter. We start dialysis, and then the patient goes for fistula, or we install catheter for peritoneal dialysis. Accesses for dialysis, or catheter or fistula or catheter for peritoneal dialysis so happens in surgery department at our surgery department in our center. So according to our data, ICU in 2019 admitted 92 patients, 99 patients, 56 had clinical and lab data of catheter-associated infections of the blood circulation, and thrombosis without infection, 43 patients. We removed thrombosis in 20 patients. I would like to say that, and patients, especially with CRBSI, because the associated infectious related infections, so they stay for a long time at the hospital, and they're very costly, and they may stay up to 96 days. This is the number of hospital stay. So the conclusions. After the use of such algorithm, patient measured with a terminal kidney failure, patient doesn't have after fistula to stay in the hospital up to 2 or 3 weeks. For the access to be possible, it decreases the number of hospital days and also decreases the rate of infections. And with the help of this algorithm, we decreased hospital stay by 14 days. The average hospital stay for a terminal kidney failure patient, now it's 8 days instead of 18 in the past. And the wide use of tunneled catheter requires careful compliance with the mooring guidelines and guidelines on central venous catheter for patients with dialysis, on dialysis. I would like to say for both hospitals and centers, so as a center and as a hospital, we do one work to improve the quality of provision of medical services, medical care, because if we save on a lock solution for central venous catheter, which cause severe catheter-related infection, will have loss of course for both the hospital and the outpatient center, which does not get funded because the patient does not attend hemodialysis, he stays in the hospital. And the savings, when we avoid CRBSI, we need to pay first and that get good results. Thank you for your attention. Dear colleagues, if you have any questions to Sergey, so ask me these questions related to this algorithm, and I could make a presentation of it. This algorithm is working in all of civilized countries, and we implemented that algorithm in autumn this year, unfortunately, very, very unfortunately, it caused the following situation, that the backflow of patients increased, the reverse flow. After installation of tunneled catheter, waiting for venous fistula, the patient started to get outpatient clinic dialysis in the centers of private and state partnership, and they come back to our center with catheter-related infection or catheter dysfunction. I know the centers which do not use tower lock, though they are obliged to. And knowing that, and I use this assembly to warn everyone that you need to be honest and you need to use, and using the words of our old king, so we will come after you. And now we will control and do the checks, the frequency and the share of the use of the product which is officially included into technological card, meaning the technical requirements guidelines. It will improve the quality of life of patients, decrease hospital costs, and finally, it will get us to what we all wish. We wish our nephrology to develop in a modern way. Does anybody have any questions? Yes, Angela. It's just not a question to you, Oleg, maybe not to Sergey, but to our dear professors. Thank you for wonderful lectures once again. Sergey demonstrated 20 catheters with removal of thrombosis. Do you use fibrinolytics with a long term? Do you use in your countries the so-called thrombosis of a catheter with the help of a long-term use of fibrinolytics?
So what we have is we do not use on a regular basis alteplase, if this is your question. We use it only as a rescue. And the urokinase, which now is our standard protocol, is used once a week on a regular basis, so as a fibrinolytic. That was.
No. If there is catheter dysfunction of a tunnel catheter, for example, Sergey showed in presentation 20 catheter had dysfunction, and Metalase, Actilase, and other fibrinolytics with long exposure are used. Do you use in your countries the same methods with long exposure in case of a dysfunction of tunneled catheter?
What we do is alteplase installation and then leaving it until the next dialysis, for example, long-term fibrinolytic therapy. We do that, yes.
Еще вопросы?
More questions, dear colleagues? Then let us finish with that. I think that was a great session. I hope it will be very useful for our work. Let us thank our professors. It took them a long way to get here and helped us to solve that problem. Thank you.